Hi, Adult Health 2. We are doing chapter 44. This is diabetes. We're going to cover type 1 and type 2. Slide 2 is our objectives. Slide 3, we have diabetes in general. So diabetes, just a group of disorders characterized by elevated blood glucose, okay? So keep in mind that your normal blood sugar is 65 to 99, and the two hormones that regulate sugar balance are in the pancreas. They're released by the pancreas. So we have insulin, which comes from the beta cells in the pancreas, and insulin decreases blood sugar. Okay, right? We give people, and that's easy to remember because, if we're in the hospital, people have a sliding scale, and if their blood sugar is elevated, we give them insulin because that helps bring down that sugar, right? So that is easy to remember. Now, this is the endocrine system, so if we have a hormone that is decreasing something, then we're going to have a hormone that can increase it as well. And this is glucagon. So glucagon comes from the alpha cells of the pancreas, and it can increase blood sugar. Okay. So type 1. Type 1 is, for the most part, considered autoimmune. Okay. So like with any autoimmune, you can have a family history, and then there's some sort of trigger. And this trigger can be a virus, chemical, cytotoxin, all sorts of things. The other thing to know about type 1 is that we really used to think about type 1 as being, diagnosed when kids and it begins in childhood, but they've really come to acknowledge that type 1 diabetes can begin at any point in life, even up until your 80s and 90s. Okay. So what happens with type 1, what sets type 1 apart from type 2 is the pancreas no longer produces insulin with type 1. Okay, so type 1 diabetics are always going to have to be on insulin, always. Okay, type 2, we have different medications like metformin, there's lots of things out there now that can help control type 2 diabetes because the pancreas is still making insulin. The body is just not using it as effectively as it could. So there's other med options related to type 2, whereas our med option for type 1, insulin, period. Okay. And it will be lifelong. So the insulin producing beta cells of the pancreas, they're destroyed. So they cannot produce insulin. So your person's going to be on lifelong insulin. Later onset, as if type 1 diabetes develops later in life, it may take a little bit for them to need total insulin deficiency. Because if the type 1 diabetes has developed later, that means that at some point their pancreas was producing insulin, right? It was functioning at least a little bit. And so it may take longer to need that total insulin dependency. But you have to remember too that because these hormones, insulin and glucagon, come from the pancreas, anything that impacts the pancreas, whether it's cancer, a lot of times they'll do like a Whipple procedure or, a resection essentially related to pancreatic cancer. Or you can see the pancreas get injured in like motor vehicle accidents, stuff like that. Anything like that can actually cause the person to be in type 1 diabetes now, because if we damage the pancreas somehow, it may no longer produce those hormones, especially insulin. Okay, so just keep in mind also that anything that damages the pancreas to the point that it's no longer able to produce insulin may then induce type 1 diabetes in your patient. All right. So the type 1 diabetes, this is cute little Nick Jonas here, right? He is very vocal about his type 1 diabetes. If you watch the Jonas Brothers, I think it was Netflix special, but they talked about when Nick was about like age 13 and they were touring and they're driving around and every chance they got, he would get like a big gulp and he's drinking all these sodas and drinking all this fluid and peeing all the time. And of course it was the mom who was like, this, something's going on here, right? And so they stopped, he goes to the doctor, and it turned out that he had type 1 diabetes. So, and he very much demonstrated the predominant features of type 1 diabetes, which is polyuria, polydipsia, polyphagia. Okay. Also, they tend to be fatigued because they are not getting any energy source from the foods they're eating, right? And there tends to be weight loss, even if they're eating, appropriately or even overeating, right? There tends to be weight loss related to this. Um, Diagnosing type 1 diabetes. So they're going to look at the hemoglobin A1C. And honestly, this is all stuff we look at related to type 2 as well. So, but we're going to use hemoglobin A1C. Benefit of the A1C is it gives you an average of what that blood sugar usually is. So that can look at the average over a couple weeks, a couple months, a few months even. I think it's up to 12 weeks on the A1C, so 4 months, 3 months. But it gives you an average, right? And really, if your blood sugar is remaining somewhere, between those normal limits for the most part, you're going to have a pretty normal average. If you are spiking, though, or remaining high because you have no insulin, like in type 1 diabetes, to actually break down any of that sugar, then even your average is going to be elevated. Okay, so that's why we look at an A1C. A fasting glucose. Fasting glucose means that you haven't eaten anywhere from 8 to 12 hours beforehand. So therefore, in a normal person, your blood sugar should be pretty low. Like you haven't eaten, there shouldn't be anything really going on. It should be on the very low end. But what you'll see even with a fasting glucose is still blood glucose over 200. And that's because that insulin is not present to be breaking down these sugars. They'll also do what's called a 2-hour postprandial sugar. That is after a meal. So that is looking at how your body is breaking down what you just ate. Okay. And then, of course, we do random glucoses. And again, those random glucoses tend to come back greater than 200 in people, especially with type 1 diabetes. So that kind of indicates, or it does indicate to us, that the body is not adequately breaking down the sugar. So treatment for type 1, pharmacological. This is our insulin, period. Our med is insulin. But you have to keep in mind that it's not just about taking insulin. You need to manage your foods, you need to manage your carbs, you need to exercise and stay healthy. The healthier your body is, the better everything functions, right? So the easier it's going to be for your body to deal with what sugars you do have. And, there's a lot of complications related to diabetes. You get vascular constriction, you can have, which affects everything. It can affect eyesight, it can affect the heart. We talk about all the time it affecting like the lower extremities, the feet especially, so this vascular constriction can have far-reaching complications. So the more that you can do to keep yourself healthy, okay, the better your body is going to be able to handle the challenges related to type 1 diabetes. And if you are in super good shape like Nick Jonas, then you may get yourself like a beautiful wife like Priyanka and have totally cute kids, right? So that's a consideration as well. So nursing considerations related to type 1 diabetes. It's going to be all the normal things, right? Vitals, obviously, we're going to look at blood sugars. We also worry about potassium related to type 1. Um, I's and O's because they may still be having that increased output, that polyuria, right? And then we look at carb intake. So carb intake, type 1 diabetics, and we're going to talk about this as well related to type 2, but it's carb counting. And my experience with type 1 diabetics, I've never met a type 2 diabetic that carb counts, only type 1. And 2, they will be able to tell you because they've been living with this for the most part their whole life, usually, right? So they will know, like, if I want to eat a cupcake, I need to do this many units of insulin. And that is essentially what carb counting does, is anticipate that I'm going to eat this many carbs, so I need to balance it out with this much insulin. Okay, so that is all what the carb intake, why we monitor carb intake and carb counting. With the potassium levels, so potassium levels may be decreased because of the increased volume loss through the kidneys. So this is a hypovolemic situation. And potassium could be increased because of the shift of the positively charged potassium out of the cells in an effort to maintain homeostasis, related to positively charged hydrogen ions moving into the cells related to acidosis. Okay, so you can kind of have two mechanisms at play that can result in hypo or hyperkalemia. So really, from a nursing standpoint, of course we're going to do the labs, right? But we just need to keep in mind that we need to be monitoring for those hypo and hyperkalemic signs and symptoms because our type 1 diabetic could go either direction with that. And remember, both hypo and hyperkalemia had EKG changes present, right? Just which ones. And that would indicate to you which direction we're leaning towards, I should say, with our potassium, right? So let's see, we talked about I's and O's, we talked about carb intake. So our actions, obviously we're going to be doing finger sticks. We're going to be administering insulin as ordered. Basal insulin is what the body's like normal baseline insulin is. Preprandial means what our insulin is before we eat. And then correctional is I'm choosing to eat cupcakes even though I have type 1 diabetes. So now I need some insulin to help my body control all that sugar. Okay, so that's what correctional is. Correctional helps with spikes. Okay, so that's our rapid acting sort of thing. Let's see if there's anything else crazy here. We may give isotonic fluids as ordered. Remember that our isotonics are going to stay where we put them. It's not going to cause a fluid shift. So that's going to help with any potential for electrolyte imbalances. Let's see here. We also want to make sure that we do education with our patient and families related to what signs and symptoms of hypoglycemia and hyperglycemia may look like. Hypo, honestly, is the bigger medical concern because you can go into a coma, right? So we want that family to know that, like, if your person is getting tired, if they're shaky, if they're suddenly weak, if they feel dizzy, all of that can indicate hypoglycemia, and that can result in coma and death. Okay, so that's really the bigger one. Let's see. This slide just has a little bit about sub-Q injections, rotating your sites, all of that stuff, which we already know all of that. Infection control related to appropriately using a needle, cleaning the skin, don't reuse needles, medication education. Don't forget these guys are going to be on lifelong insulin, okay? And that insulin can be affected by stuff like stress, infection, activity level, carb intake, decreased oral intake. Like let's say you're sick or something, right? Um, and we do have what are called sick rules related to diabetes, which we'll talk about. But so all of those things, so the body's not making insulin, but all of these things can still influence how the body burns through insulin, right? So our type 1 diabetic is having to give themselves insulin, but they need to take into consideration, are they, maybe they play a sport. How is that going to influence their insulin levels? Maybe they go and exercise, whatever. Also activity levels can cause hypoglycemia, right? Increased activity levels, I should say. So they need to consider, do they really want to take their insulin before they go work out, because does that put them at risk for a hypoglycemic incident? Okay, so there's a lot of considerations, as because we're artificially giving the person insulin. The body is not saying, not being able to judge. We're being the judge of how much insulin this person should have. So you really need to take all those things into consideration. And that is that. This is slide number 7. So this is a safety alert from the book. It talks about insulin being a high-risk medication. It talks about tight glycemic control increases the risk of hypoglycemia in patients who rely on insulin and or oral agents that stimulate the release of insulin. So that would be type 2 as well, right? Because if we're stimulating the release of insulin, that means the pancreas has insulin that it can release. So that would be type 2, not type 1. Risks of tight glucose control with resultant hypoglycemia may not outweigh the benefits for some patients. This includes patients with a limited life expectancy, those with comorbidities where a hypoglycemic event will have more serious consequences, or those unwilling or unable to do the monitoring necessary to prevent hypoglycemia. This risk is especially pronounced in patients with a tendency toward hypoglycemia, such as older adults, malnourished, or those with renal or liver disease. So what this is basically saying is that, all right, we talk about like using insulin and metformin and whatnot to try to maintain glucose within normal limits. But if we are dealing with someone who has a tendency or a bigger risk of going hypoglycemic related to the use of these meds, then it may not be worth using these medications. They may be better off sitting a little bit higher with their glucose rather than risk a hypoglycemic incident, because like I said earlier, hypoglycemia is actually the one that can result in coma and death. Okay. So glucose management plans. You can see in this picture, cute little Nick Jonas, he's got one of those digitally continuously monitoring blood sugars. That little white thing on his arm, that just sticks right in there. The nice thing about those is they can be hooked up to a phone, they can be hooked up to a machine, whatever, and that will alert you when your sugars are out of range automatically. So it's continuously monitoring. You don't need finger sticks, you don't need any of that. It also makes it really easy to track and trend what your glucose is up to. So, in that way, we're always trying to aim for a treatment plan that mimics the response of a healthy pancreas, right? So, if you are receiving continuous blood sugar readings, and it's going to help you maintain better glucose control because you are able to respond more immediately to those glucoses that may be out of range versus like, oh, I need to take a finger stick, but my stuff is in the car and I'm grocery shopping, so I'll be there in an hour, sort of thing, right? So this just helps kind of give more accurate, frequent readings, which allow for sooner response. Okay. Insulin is never going to be zero in a healthy person because that's that basal level insulin. A minimal level of insulin is maintained throughout the day. So this is going to help with that. And then think about like at meal times, we anticipate there being a sharp increase in sugar, which means that there's going to be a sharp increase in insulin secretion, right? Because the pancreas is in a healthy person is going to respond by releasing that sugar. So what Nick Jonas is wearing here reads the sugar level, but also there are insulin pumps that can then release insulin in real time. Okay, so you can have an insulin pump, you read your sugar, you see blah, 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 I need 2 units, and you can either prompt the insulin pump to release the units, or nowadays the insulin pump is connected to the continuous monitor. So they talk to each other. So that's kind of interesting. Now, the only consideration is that sometimes these things can backfire. Also, sometimes pumps can run out of insulin. That insulin store needs to be replaced. So that is another consideration. People need to be able to be willing to monitor their equipment and maintain their equipment if this is the equipment that they're going to be using. Okay. We also still talk about finger sticks before meals, right? And that way you can adjust your insulin as needed and accommodate related to whatever you are eating. Our long-acting insulins are what give us that basal insulin coverage. Okay, so that basal insulin is what keeps the insulin level never being zero. It's never zero. That's our basal insulin. Long-acting mimics that basal insulin. Okay, short-acting is what we use when we're going to have spikes. So when we eat. Okay. Slide number 9 here is just kind of a nice little diagram of what the insulin looks like related to glucose levels. So this is what a normal pancreatic response would be. So just kind of a cute little slide. It's straight out of the book. Also on page 1035 of the book is a table 44.3. It shows types of insulin. So if you feel like maybe you aren't totally familiar with your insulin, take a look at that. Unfortunately, types of insulin has NCLEX written all over it, right? So you're definitely going to want to make sure you remember those. Slide number 11 is figure 44.4. This shows what basal and bolus insulin therapy kind of looks like related to spiking. So just another, if you like a visual, that's a nice little visual. Slide number 12. So slide 12 is box 44.4 out of the book. It talks about carb counting. Okay. Now, like I said, the book talks about carb counting related to type 2 diabetes. There is a question on the test asking about carb counting related to type 2. The only people I've ever met who carb count are type 1s. period. But so carb counting, it's a technique useful for managing blood glucose levels, understanding the carbs that are contained in a food, and that, carbs are what raise the blood glucose level, right? So what people do is determine how many units of insulin they should take based on how many carbs they consumed. So take a look at this slide. It is slide 12. We will talk more about this in class though, okay? And we have some worksheets for you to look at. Slide 13, methods for assessing glycemic control. We pretty much already talked about that, right? But here's cute little Nick Jonas again, okay? So we have finger sticks, meters, you can do levels in real time with the meters. Errors can be related to maybe not sampling enough blood or improperly cleaning the area, okay? Continuous glucose monitoring, like we talked about, there's a sensor inserted underneath the skin, and then it may alarm when your glucose levels get too low. And then, of course, we always want to monitor that hemoglobin A1C. So one of the biggest complications related to type 1 is DKA, diabetic ketoacidosis. So remember, there's inadequate insulin for cells to obtain adequate glucose for normal metabolism. So what happens is the body attempts to obtain energy by breaking down fat stores. So this is going to release fatty acids from adipose tissue. So the liver then goes and converts those fatty acids into ketones. And then the ketones can serve as an energy source when there is not enough glucose. Okay. So the ketones, so here's the thing, here's the problem. The ketones have a low pH. So the body has released, the liver went and released all these ketones. It felt like we didn't have enough sugar. So the body released all these ketones that have a low pH. Okay. So this results in a state of metabolic acidosis. Low pH means that they are more acidic. Remember? So if we go, here's our pH and we travel down the scale, we're actually getting more acidic as we go. So our person ends up in metabolic acidosis. All right. The absence of insulin can also result in an increased release of hormones like glucagon and cortisol in response to inadequate glucose transport. So this can lead to gluconeogenesis and glycogenolysis. Glycogenolysis is the breaking apart. Gluconeogenesis is the making of new glucose, okay? But this can all result in severe hyperglycemia because the body is freaking out and making new glucose, and it's also freaking out and blowing apart glucose, which ends up with free-floating glucose in the blood, and all of this leads to hyperglycemia. Okay, so extreme hyperglycemia results in hyperosmolality and osmotic diuresis. Okay, so this is all a problem. This all needs to be back under control, okay, with the DKA. So remember, causes of DKA can be related to missed or reduced doses of insulin. It can be related to inadequate insulin. Okay, maybe the person is under stress or infection, and maybe they took insulin, but it was not enough. So inadequate insulin can cause this. Also, it is not uncommon for people who didn't realize they even have diabetes type 1 to be in DKA. And a lot of times it'll be the signs and symptoms related to DKA that bring people into the hospital, and then they end up with their diagnosis. So the signs and symptoms, we're going to see those 3 P's again. That polyuria, polydipsia, polyphagia, right? Dehydration, okay? Electrolyte imbalances. Especially we are always worried about potassium. Our person may be tachycardic, they may be hypotensive, and they may have Kussmaul's as the body tries to blow off the acid. Without treatment, the patient becomes hypotensive, tachycardic, related to volume loss. Like I said, they're going to have Kussmaul's. This is a compensatory mechanism for that metabolic acidosis, right? The body is trying to blow off CO2, which is an acid, okay? So it's a compensatory mechanism to metabolic acidosis. That breath is going to have that fruity acetone smell, and that's related to those ketones, okay? That overabundance of ketones. The patient could have abdominal pain, nausea, vomiting, maybe they're tired. So when we look at DKA, that blood glucose level is going to be greater than 250, okay? It's going to be greater than 250. Also, we're going to have ketones in the urine. Our pH, our arterial pH, our ABG, is going to be less than or equal to 7.3. So it's going to be acidotic. Our person is going to be metabolic acidosis, okay? And then that serum bicarb may be equal to or less than 18. It also talks about a positive anion gap, okay? This, if you want to read the definition of an anion gap here, it's on slide 14. Basically, it has to do with the positive and negatively charged ions in the body related to the metabolic acidosis, okay? So we expect a positive anion gap. We are going to treat with isotonic fluids, okay? We're going to monitor for and treat any electrolyte imbalances, and then we are going to give insulin. Now, the one thing like that you really need to think about with DKA, your person is sitting at a glucose greater than 250, right? We don't know how long they've been there. We don't know how long they have been sitting at an elevated glucose. So when we are talking DKA, we don't want to give enough insulin to like drop our person back into normal range, like 9 all the way down to 99, because the body may actually see that as being hypoglycemic. Think about if your body has been functioning, sitting, dealing with a glucose of 300, and suddenly we're going to go and dump you back into a normal limit of like 80, right? Or even 100. Your body is going to think you're hypoglycemic. And so even though you're not technically hypoglycemic, right? We wouldn't look at that sugar and think that you're hypoglycemic. But if your body thinks you're hypoglycemic, it is going to respond like you are in hypoglycemia. And remember, that can mean coma and death, which is bad. So when we are reducing sugars in somebody, if they're in DKA, you reduce those sugars slowly because we don't want the body to go, oh my gosh, now we're hypoglycemic and respond to the hypoglycemia. Okay. Slide 15 just shows the clinical manifestations related to DKA. So that's a nice little visual there. Slide 16 talks about the potassium imbalances related to DKA. So initially, our person is going to be hyperkalemic, related to the movement of potassium out of cells into extracellular space. Okay, so first we're going to be hyperkalemic, and then as we treat the hyperglycemia, we're going to use insulin. What is our treatment for hyperkalemia, right? Insulin and glucose, because that insulin is going to push that potassium back into the cells, okay? And then when we're just treating for hyperkalemia, we give glucose so that we don't end up hypoglycemic, right? So we're giving insulin to treat DKA. What's that insulin going to do? Yeah, it's going to treat the sugar, but it's also going to push that potassium back into the cells, okay? So we worry about that. So now we got to think about stuff like arrhythmias, all that stuff related to hypokalemia. Okay. So that's another reason we kind of go slow with our insulin, is because we don't want to change, alter these levels too suddenly. Okay. We need to be able to monitor and treat as we're going along. All right, so complications related to hypoglycemia. This this is life-threatening, okay? This can have life-threatening effects on the CNS. The CNS relies solely on glucose for energy, all right? So if our person has a glucose less than 65, or like we were talking about, if they're in DKA and we dump their sugar too quick, the CNS is not going to be happy. You get things like anxiety, hunger, palpitations, that circumoral tingling. Remember, that's related to low calcium levels, sweating, shaking, irritability, altered level of consciousness, red flag, slurred speech, red flag, seizures, coma, death. Okay. Um, if patient, this is kind of interesting too, because we always talk about wanting good glycemic control related to diabetes, okay? So one of the reasons is because if the patient frequently experiences hypoglycemic episodes, the body actually stops responding to it. So even though like anxiety, hunger, palpitation, sweating, shaking, irritability, all those things, that's not great, but that's our body warning us that our sugar is getting too low. Well, if you let your body get hypoglycemic too often, the body gets used to it, right? The body gets used to it, and so stops indicating that you are hypoglycemic. So we don't have any early warnings anymore. So that means that sugar could get so low that you slip into that seizure and or coma, because we didn't even know you had low sugar to start with, because your body didn't indicate to us that it did. Okay. So treatment for hypoglycemia, ideally food, right? Ideally some sugars. Glucagon potentially, in a facility, we're going to use dextrose or glucagon, depending upon what's available. All right, slide 18. These are the sick day rules. So these are sick day rules for people with diabetes. This is type 1 and type 2. And that is because when we are ill, the body handles sugars differently. Okay. And if you're type 2, you may produce insulin differently. If you're type 1, maybe your intake is down, so you're not getting the normal carb intake that you do, and therefore you want to adjust your insulin accordingly. But you people should have a sick day plan, a diabetes management plan in place in case of illness. Okay. So this is something you talk with your provider about. You want to be checking your sugars regularly. You want to be aware of and prepared for hypoglycemia. You want to make sure you have your supplies on hand. Okay. You want to be aware of potential complications like DKA. The biggest thing is planning ahead. All right, planning ahead, because you never know when you're going to get sick, and then you may not feel like going out, or maybe you can't go out, or whatever the case may be. So it's really important for people to make sure that they have supplies on hand. All right. Slide 19. This talks about the dawn phenomenon and the Samoji effect. So basically, both of these result in an increased glucose level in the early morning. Okay. They are more common with type 1. The dawn phenomenon is just caused by natural release of hormones in the early morning, and the body does not have enough insulin for coverage, so blood sugars actually rise, right? And so what you'll see is a higher fasting glucose level in the morning. So you would think like, well, I haven't eaten all night long, my sugars should be pretty low. But what you'll see is that morning reading will be elevated. So with the Samoji effect, this is super rare, but it's related to unrecognized low glucose during the night. So what the body does, the body's going to respond by release of hormones and stored glucose from the liver, right? So what happens is then you get this uptick again. So if in the early morning, the glucose level, and by early morning, we mean like 2 or 3 a.m. So if at about 2 or 3 a.m., the glucose level is low, then it's likely the Samoji effect. If that 2 or 3 a.m. Glucose level is high, then it's likely dawn phenomenon. Okay. So just two different kind of things that you can see. All right, moving on to type 2 diabetes. So this is non-insulin dependent, right? The pancreas is still at least making some insulin. Maybe the body's not using it, but it is there, okay? This used to be, type 2 used to be more common in adults versus kids, but now, unfortunately, because of the increase in obesity and inactivity, we're actually seeing more type 2 in kids. So it's not just limited to adults anymore, which is unfortunate, right? With type 2, you still, a lot of times you still have that genetic predisposition, but then there's the modifiable risk factors, okay? So that's all your lifestyle stuff, your diet, being sedentary, not taking good care of yourself. Also, if you had gestational diabetes, so if you developed diabetes while you were pregnant, and that gestational diabetes is directly related to the pregnancy, but it does put you at greater risk for developing type 2. Also, polycystic ovary syndrome for can cause type 2, predispose you, increase your risk factors for type 2, cardiovascular disease, and then metabolic syndrome, which we will talk about. So insulin resistance refers to needing increased levels of insulin to drive the glucose into the cells, okay? The beta cells may fail, the insulin production declines, which can require exogenous insulin administration. That just means we're giving you insulin. Now you need to take insulin because the body is either not making enough or not utilizing what is there. So the signs and symptoms, very, very similar to type 1. You have those 3 Ps, right? Also, we always talk about poor wound healing. And this is related to the high sugar in the blood, okay? You may end up with cardiovascular disease related to high glucose. You can have visual disturbances, renal insufficiency, and recurring infections. So the CV and the visual disturbances, renal insufficiency, all of that can be related to the vasoconstriction. And then the recurring infections can be because you have a high sugar content, and bacteria is like, yes, please, right? And won't go away. It's happy. It has all it needs to live. Diagnostics, also the same as type 1, because we're going to want to differentiate, right? So what's one of the weird things is, and I didn't talk about this in type 1, but when they do labs, they can check for insulin antibodies. And remember, type 1 is very often an autoimmune disease. So you can actually have insulin antibodies. This is going to be positive with type 1, but negative with type 2. Okay. And then of course we're going to do all the A1Cs, the finger sticks, the fasting, the glucose 2 hours after eating, all of that stuff. Treatment, we have PO meds like metformins, we have GLP-1s, and then of course potentially insulin, right? But type 2 diabetes, a lot of modifiable risk factors related to this. A lot of times losing weight can help get people off of insulin with type 2 diabetes, just because they are maybe initially needing insulin for control. If they go and lose a bunch of weight, change their diet, exercise, all those things, it is possible for type 2 diabetes people to get off of insulin. Okay. Whereas remember, type 1 people will never be off of insulin because the body's not making it. Okay. Slide number 21 is metabolic syndrome. So metabolic syndrome is really important to diabetes, to cardiovascular disease. This is a cluster of risk factors that include resistance to the action of insulin, hypertension, high cholesterol, hypercoagulability. Most often, patients who meet the criteria for metabolic syndrome are overweight. A patient is considered to have metabolic syndrome if 3 of the following traits are present. So if they have abdominal or central obesity, if they have increased serum triglycerides greater than or equal to 150, decreased high density lipoproteins, so those are the good HDLs. So if their HDLs are less than or equal to 40, hypertension greater than or equal to 130/85, a fasting glucose greater than 100. Okay, so if they have 3 of those traits, they are considered to have metabolic syndrome, and that puts them at increased risk for type 2 diabetes and or cardiovascular disease. Okay. If you like a table, this is page 1046, table 44.5. This talks about oral and non-insulin injectable glucose control agents. So your Ozempics and all of that sort of stuff. Okay. Or slide 23, table 44.6, page 1048. These are dietary guidelines. So take a look at that for sure. Complications related to diabetes type 2. So you can have hyperosmolar hyperglycemic state, HHS. Okay. This is basically hyperosmolality, dehydration, hyperglycemia, but you don't get that ketoacidosis related to that ketone release. Okay, so it's similar to DKA, just no ketone involvement. So this is enough insulin. The body has enough insulin to prevent ketone release, okay, but not enough to prevent hyperglycemia. All right. So that's why you won't see this with type 1 diabetes, because with type 1 diabetes, we don't have enough insulin. Okay. So with this, there's enough insulin, so ketones don't get released, but you still end up with hyperglycemia. So this is a glucose greater than 600. Greater than 600. Isn't that crazy? So we are going to treat dehydration. We're going to give IV insulin. We're going to worry about altered level of consciousness. Again, we do not want to drop our person too quickly because the body is going to think it has gone hypoglycemic. And that is our biggest worry. All right. So now a complication related to 1 and 2 is hyperglycemia, okay? The problem with hyperglycemia, like we talked about, puts you at risk for poor wound healing, puts you at risk for infection, adversely affects the vessels and nerves. It damages the lining of those vessels. And like we talked about with the cardio stuff, smoking damages the lining of the vessels. And anytime we damage that endothelial lining, you run the risk of it's not as easy for all the things to move freely through the vessel. You put yourself at risk for clotting and obstructions because if the inside lining of that vessel is damaged, it's easier for things to grab on and hold and stay in place and get stuck. And so then you end up with clots, obstructions, all the things, okay? And so this consequently can result in cardiovascular disease. The leading cause of death related to diabetes is cardiovascular disease, because you end up with this narrowing of the vessels and you end up with this clotting and obstructive factors, right? Another complication related to hyperglycemia is diabetic peripheral neuropathy. That is the damage to the neurovascular system, especially in the lower extremities. We also have autonomic neuropathy. This is damage to the nerves of the autonomic nervous system. So this can result in like diabetic gastroparesis, which is delayed emptying of the stomach related to the nerve damage. So then the glucose can spike if food hits the intestine at an unexpected rate, right? So that's a problem. Also, you can end up with erectile dysfunction when you have autonomic neuropathy, orthostatic hypotension, and urinary problems. Okay, so a lot of damage caused by just too little or too much sugar in the system. Are in considerations for diabetes type 2. So our assessment, sugar, right? We're also going to worry about cap refill in the lower extremities related to the fact that we know there can be vascular damage. We're worried about skin, especially again, lower extremities. We're worried about eyes and nose. We're going to look at infection stuff like WBCs because we know that our person who is sitting in a hyperglycemic state is at a greater risk for infection. We worry about the kidneys, so we're looking at BUN, creatinine. Albumin in the urine can actually indicate early vascular damage. And then we're going to see if they know how to carb count or even know what that means, right? Do they monitor their carbs? Do they know how carb intake is related to insulin use? That sort of stuff. Actions, obviously finger sticks, meds, probably isotonic fluids. Teaching is going to be related to all of that, meds, finger sticks, glucose monitoring, etc. But also with type 2, you cannot underestimate the importance of those lifestyle changes. And then, of course, monitoring for signs and symptoms of hypo and hyperglycemia. The sick rules also apply. And then we want to talk to them about vascular complications, like why heart disease is a problem related to diabetes. Because the benefit of type 2 versus type 1 is that we do know those modifiable risk factors can have a huge influence on overall outcome. So you can live a healthy life with type 2 diabetes as long as you are managing all of those lifestyle things, right? So that's just a huge education opportunity. All right, so that is diabetes.